Hello, and welcome to another in our informational seminar series dealing with liver diseases. Today we have Dr. Jeffrey Schwimmer talking about fatty liver disease and NASH in children. And it's very propitious that we have him here today because it is National NASH Day. And we've already talked to several of our Congress members about a bill that's in front of them for dealing with NASH. So we're very happy that this is going to be going on today. We have experts providing all kinds of useful information about liver disease, and they are all available on our website, the Liver Coalition website. So please check them out. We started the Liver Coalition a year ago to fill a void that was created during the pandemic. And we were able to create a new organization, a new 501c3, and all the money that's raised here in San Diego will be staying in San Diego, unlike what happens with national organizations. So again, please look at our website for more information, and we want to thank you so much for attending today. I want to definitely welcome you and say how happy we are that you're available. We're going to do some sponsor highlights now because our sponsors help us be able to afford to put on these webinars. And the first one will be Gilead. And I don't believe Greg is on, but I want to thank Gilead very much for their sponsorship. And our next one is ASI Pharmaceuticals, and we have a video from them which we'll play right now. Thank you again, Abby, for your support. It's very much appreciated. And we'd also like to thank Intercept for their sponsorship of these webinars. And now it is my pleasure to introduce the co-chair of our Associate Medical Advisory Council and a physician assistant in the gastroenterology department at Scripps Hospital, Melissa Ferrari. Melissa, take it.
Hello, everyone. Thank you so much for joining us again tonight. Thank you so much for the introduction, Terry. As you said, I'm a physician associate in gastroenterology at Scripps and the co-chair of the Associate Medical Advisory Committee of the Liver Coalition of San Diego. We have a great presentation for you tonight. Dr. Jeffrey Schwimmer is a pediatric gastroenterologist at Rady's Children's Hospital, and very fitting that he's going to be talking about non-alcoholic fatty liver disease and NASH in children on National NASH Day. During the presentation, if you have any questions, please do use the questions portal on the side of the page there. I will be fielding these questions. Most of the time, we do wait until the end for me to kind of be the mediator between your questions and discussing with Dr. Schwimmer. But if I feel like anything is very pertinent, we can always interrupt during as well. I feel like that's all the housekeeping we need for right now. So Dr. Schwimmer, when you're ready, you can connect.
So thank you, Melissa, and thank you to the Liver Coalition of San Diego for this chance to spend this time with you. As mentioned, I'm going to be talking about NAFLD and NASH in children. And for those of you who don't know, we started the first pediatric clinic for fatty liver disease in the United States at Rady Children's Hospital back in 2002. So next year will be our 20th anniversary. Our team includes myself as director, along with Dr. Kimberly Newton as our assistant director, Reese David, one of our lead nurse practitioners, and Karen Putnam, our nurse case manager. In addition, the Schwimmer lab at UCSD is a group of about 15 people focused on NAFLD and NASH in children and in families. Our lab manager is Patty Ugaldo-Nakalo. And then again, along with Dr. Newton, Dr. Goyal, Dr. Yu, and Dr. Shapiro are all pediatric gastroenterologists working in the lab as well. So this evening, I'm going to talk about what is NAFLD, why does it matter, and what should you do about it? Okay. So here we see a liver, and the first thing I want to do is actually set aside some misunderstandings. A lot of people, when they hear the phrase fatty liver, think that it either means perhaps a big glob or ball of fat in the liver, or some people think it's a large band of fat around the liver. But this really is a cellular disease. The liver is made up of almost 100 billion cells, and this condition really happens at that level. So here we see a normal liver here, and here we see steatosis or a fatty liver here. And these white spots are where there are big droplets of fat inside individual liver cells. And so the difference between a normal liver and a fatty liver. Moving on, the difference between a fatty liver and fatty hepatitis, we move from having those fat droplets, but not much else in the way of liver injury, to actually having overt inflammation and cell destruction, and that is what's termed NASH. This is a form of hepatitis. And then moving from NASH onto fibrosis or liver scar tissue, here we see NASH with cirrhosis, these big, thick bands of scar tissue. And so it's those children who have the NASH form of this broader condition, NAFLD, that are at risk for developing scar tissue, which can extend all the way through to cirrhosis. Now, as far as the natural history, what happens to children who develop this disease? For those last 2 decades, and you can all anticipate us giving you some very detailed information on this next year. One thing to keep in mind, we are talking to families tonight, is that this is a genetic disease. We've shown that there is a very high heritability to this disorder. And so when we see children who have NAFLD or NASH, about half the time, there is one or more family members who also have the disease, whether they know it or not, And about half the time, that child is the first one in the family to have it. Now, I think of having NAFLD or NASH really as, in many ways, being a check engine light. It signals not only this liver problem, but that there are greater chances of a multitude of other problems. And we'll touch upon each of those a little bit. So starting with the liver problem, what happens is that some of these children will develop cirrhosis. As children, at the time that we first diagnose them, it's about 1 to 2 per 100 that already have cirrhosis. It's about 10 to 15 per 100 that already have substantial scar tissue and are well on their way to cirrhosis. And perhaps the biggest impact is what we're seeing in early adulthood and in adults in their mid to late 20s to early 30s is where there's been a very large increase in the impact of what's called cirrhosis leading to end-stage liver disease. And so a critical piece of it is that if children go undiagnosed and then on to adulthood where they're less likely to see a doctor, they may not have a chance to do something about their liver disease. So a key message is that there are screening guidelines in place. People should talk to their pediatricians about these. Moving on to the what are called extrahepatic or non-liver consequences. First and foremost is diabetes. In children, having NAFLD is the single biggest risk factor for developing type 2 diabetes. We have shown that about 6% of children with NAFLD have diabetes already at the time that they are diagnosed with liver disease. And another 23%, almost 1 in 4, have pre-diabetes or are at a very heightened risk for developing diabetes. Anecdotally, we've seen that a lot of that diabetes has happened in later adolescence and on to early adulthood. And we've seen that among children who have NAFLD, those that have diabetes are much more likely to have worse disease, to have the NASH form, to have more liver scar tissue. Another major element is cardiovascular disease. And this takes a few different forms. One are lipids and one is blood pressure. So with respect to the lipids, we're really talking about having high triglycerides and having low HDL cholesterol. Those are the two that are most commonly associated with NAFLD. It turns out that about half of children with NAFLD have triglycerides high enough that they would merit intervention onto themselves. About 15% of children with NAFLD have LDL cholesterols that are high enough that they would merit intervention onto themselves. So certainly all children who have NAFLD should have lipid screening done and analyzed. With respect to blood pressure, we also see very high rates of hypertension. In part, the insulin resistance that underlies fatty liver disease is a big contributor to blood pressure elevation. It is about a third of children with NAFLD who will have elevated blood pressure, and even after dietary interventions, about 20% or 1 in 5 will have persistent hypertension. So certainly a number of children with NAFLD will eventually need medication to treat their blood pressure. Moving on from the heart to bone health. And so we often may think of osteoporosis as a problem that really isn't relevant till much later in life, or maybe it's a problem that is predominantly affects women, but it turns out that children who have NAFLD have a high risk for having less well-developed bones. And so you see here, this is a nice, dense, healthy bone. And as these progress and have less mineralization and bigger air pockets, less strength to the bone, this is what osteoporosis looks like on the inside. And so one of our concerns is that children with NASH are going to be at greater risk for having fractures as adults. The bulk of bone density, bone mineralization occurs in childhood and young adulthood. And so if there are already impairments in that and they're not detected and addressed, it sets people up for this problem down the line. Moving from bone health to mental health, we've just looked at a 4-year study where we tracked adolescents with NAFLD from early adolescence through late adolescence, and we saw that the development of new cases of both depression and anxiety exceeded the rates of adolescents in the general population. And interestingly, we also saw that those adolescents with NAFLD whose liver chemistry, their ALT value, was increasing were in fact the ones who were more likely to develop depression. And so many of you have heard of a mind-gut connection and a liver-gut connection. Well, I think we're putting together the liver-mind connection there. So moving from why does it matter to what do you do about it? First and foremost is nutrition. This is the cornerstone of all action. As you know, everything that we eat goes from the mouth to the stomach to the intestines. As it is digested and absorbed, it must pass through the liver for processing. And so some foods make it easier for the liver to function, and many foods make it harder. So we see spinach here because dark green vegetables are quite good for the liver. In terms of things that may be problematic, at the top of that list is added sugar. And so this is in some obvious places like soft drinks or cookies or ice cream, but it also is in a lot of places that may not be obvious. A lot of sauces or dressings, yogurt, are all places where there can be a lot of added sugar that people don't necessarily think about it. So it is very important to read labels. We actually did a study where we worked with families and provided them with a low added sugar diet to the entire family. And we saw that that led to a substantial reduction in liver fat in teenagers with NAFLD. And we think that this is probably pertinent to both children and adults with this condition. In addition to sugar, then we sort of move to the ultra processed foods. And these are things that are increasingly gaining attention as likely to contribute to extra calorie intake for a lot of us, as well as promoting inflammation, leading to a less healthy gut intestinal microbiome. And the constellation of those things then adds to this problem. Moving from nutrition to physical activity, and it really isn't just exercise, it's really how do we spend our time, both time in movement and time that is sedentary. And so the recommendations for children are to have 60 minutes of physical activity every single day. And it turns out that if exercise is part of what one is seeking for not only weight loss, but preventing the regain of weight that has been lost, it takes about 10 hours of physical activity per week. So actually a little bit more than an hour every day. That's on average. Every person is a little bit different, of course. Moving from exercise to life balance. This really encompasses many things. The impact of stress and chaos, not just on the mind, but on the body and our metabolism, is something that we are really still learning about, but we have observed makes a big difference. And so it's not just eating quote unquote right or being active, but it's really sort of, doing all the things that bring harmony to one's life. And then sleep, which is certainly part of that as well, is something that is very important. And this is both getting enough sleep and quality sleep, because a lot of the repair work and metabolic work of the liver occurs while we're sleeping. And so if we don't get enough sleep, it doesn't happen right. A lot of the genetics of this liver condition actually work with what are called clock genes that function on different times of the day, again, reinforcing the importance of enough sleep. We also see that a lot of children with NAFLD may be more likely to have sleep apnea, with the most obvious symptom being snoring, but certainly poor sleep quality, fatigue are things where that perhaps should be explored as well. And so it's a very quick run through of what NAFLD is, what NASH is, what scar tissue is, what some of the consequences of NAFLD and NASH are, and some of the big picture things that one can do and should do. And so again, I'm very appreciative of the Lower Liver Coalition for organizing these seminars, and I look forward to a robust question and answer session.
Hi, thank you so much. What a great kind of comprehensive kind of walking through a lot of the things that you have to deal with and what's important, right, for families in general, right, and how it's a big process altogether to make sure that our children are taken care of. So, firstly, I guess going through all those I'm so sorry. Can you hear me, Dr. Schwimmer?
Yes, I can. Thank you.
Oh, okay, and you can see. Oh, there it went. I wasn't seeing my webcam come up.
Now I can see you. Yeah.
Okay, but you did hear what I said?
Yes.
Perfect. I guess from a clinician standpoint though, right? It's easy to give all of these recommendations, especially like to families, to say we need to make these changes in a child's life. But I guess I'm just wondering from your perspective then, I mean, it's really not so much in the child, it's really engaging the family then, right? So do you find that people are rather receptive in these changes and like as a family to help?
Yeah, thanks, Melissa. It's a very good question. I think that, so one of the things that's certainly true in pediatrics is age matters. So if we're talking about an 8, 9, 10-year-old, it's certainly different than if we're talking about a 16, 17-year-old in terms of what that balance is between child and parent. There's no question that, as I said, this is a genetic disease. Many times there's a family member who also has it. And so the kinds of things we're looking for the child to do are really things that would be good for the whole family.
Of course.
I would say the most successful patients are the ones where there is buy-in across the whole family. And that means not only, say, the parent who has come to the appointment, but the other parent as well. Part of it is really appreciating that there can be quite a difference in what one's background state is. So some people will come to us and still have a lot of what we call very low hanging fruit. They are drinking a lot of soda, let's say. Others, perhaps because these things are more known in the general population, or maybe their pediatrician has already made some recommendations to them, have already done some of those easier things. So I think part of it is really sort of understanding the child and the parents and the family as individuals. Where are they? What have they already done? What has or hasn't worked for them, so that as we're guiding them, it's in the context of their own specific needs. I think that some of it is what is people's motivation, right? So some people are more ready and willing to work on one arm than the other. So they may be more primed to do something about their diet than physical activity. In some cases, maybe they're more interested in doing exercise than they are in changing their diet.
Mhm.
And this is a lifelong disease. And so it's okay for it to take some time to do all the things we want a person to do. As long as we're making forward progress, that's a good thing. So sort of figuring out what are they motivated to do and working with that. And as they see positive changes by the things they're able to do, often it will support being able to add on to that.
Absolutely. Also wondering, you had mentioned that a lot of the times that independent of finding that fatty liver disease or NASH, a lot of these children will have like isolated like problems with their cholesterol anyway that probably should have been addressed, or the diabetes issues that would have been addressed. Do you ever find, or is it common to find some of also those genetic like cholesterol type issues in these patients as well?
So as with respect to say familial hypercholesterolemia, um, we do see some patients who will have extremely high cholesterol in the context of familial hypercholesterolemia. We also actually will see some patients who have very low cholesterol, uh, maybe a few percent will sort of develop their fatty liver on the context of having a defect in not making enough
Mm.
apolipoprotein B, and the sort of signal to that is that one's LDL is extremely low, less than 50. And so I think, if you look at the liver, there are a lot of ways that one can get to steatosis, can get to fat in the liver. So the most common is certainly that which is associated with excess body fat, insulin resistance, but it's not the only. And the way I think about it is that you can get to a fatty liver both through a lipid arm, through a fat-driven arm, as well as through a carbohydrate-driven arm. And
Mhm.
so when you sort of start breaking it down for the individual child or family, the more you can understand about how they got there, both genetically and environmentally, the more you can sort of unravel what's going to be the best therapy for them.
Makes sense. And then just to touch briefly on, I guess, the diabetes perspective of that, in your clinical, I guess, experience, do you find a lot of like, I guess, young children diagnosed with like type 1, right? So like an autoimmune kind of condition, if they're not well controlled, are those children also at risk for developing this fatty liver?
So rates of fatty liver disease in children with type 1 diabetes are not particularly high.
Okay.
They're more likely to have a lot of glycogen in the liver. They certainly are at risk for developing celiac disease. And there is an interconnection between celiac disease and liver disease. And as you mentioned, it's autoimmune. So we do see some children with type 1 diabetes who also have autoimmune hepatitis. So I think one of the important things is always make sure we're making the right diagnosis.
Right.
I think that more recently, there are children who have type 1 diabetes and have obesity, a constellation that didn't really used to exist. And so there are some children who we're seeing with NAFLD or NASH as part of that constellation. And I think we're working in a different landscape.
Understood. And I guess just actually out of my curiosity, as I used to work with adults, right, liver disease and NASH, and how we're able to move away from some of the biopsy like gold standard of making diagnosis of advanced liver disease and using some of these other modalities. Are those other modalities actually used in children right now, like FibroScan and other things like that?
Yeah, so it's a really good question. And so, you can sort of break it down into there's conventional ultrasound, there's FibroScan or other forms of transitional elastography, and then there are MRI-based measures, MRI proton density fat fraction, and MRE,
Mhm.
MR elastography. And so conventional ultrasound turns out to actually be pretty limited in its accuracy for fatty liver in children. And so the guidelines from North American Society for Pediatric Gastroenterology and the guidelines from the American Academy of Pediatrics actually don't recommend using ultrasound as a diagnostic tool because of that high error rate. It is still widely used, but it creates a lot of confusion. With respect to transelastography, FibroScan, there really are not adequate data in children. The data we have thus far, so again, FibroScan has two different components to it, right? There's CAP to look at steatosis, and FibroScan to look at stiffness or proxy of fibrosis. So as a proxy of fibrosis, you really then need biopsies as the comparator. And so there really have not been enough studies in children that have had FibroScan in a population of children with NAFLD with a range of fibrosis to make the assessment. With respect to CAP, CAP has not proven to be much better than ultrasound in children. A large paper from Japan showed it worked pretty well in thin children, but not very well in children with obesity. And unfortunately, that's mostly what we're dealing with is children with obesity. And then in a paper in the Netherlands, when they compared it to MRI, they also saw that its accuracy really wasn't quite good enough for clinical use. So I know people have started using that as well, but you have to be very careful. I think the technology that's by far the most promising is, of course, also the most expensive, which is MRI.
Right.
And so we have shown that MRI is a very good measure of liver fat. It is a good measure, not of liver fibrosis. It's not as good for fibrosis, MRE, as it is for liver fat. I'd say the liver fibrosis part of it is great for research, but is really, that part is still a work in progress. And so it is a real challenge in terms of deciding when do we need the information that we can only get from histology. And then one of the elements to that is in children, there's actually not just one type of NASH, there's actually two different kinds of NASH that we see in children. And that's a distinction that we can certainly only make on histology right now. So a lot of talk on how can we move past having to rely on histology, but we're really not there yet.
Understood. In adult patients, right, who have NASH, we do our best to try and like limit progression and hopefully not have them need a transplant in the future. I guess I'm just wondering about the statistic in younger patients, in children. How often do you see like the pediatric population actually need a transplant within still a pediatric lifespan and not as an adult?
Yeah, the number is not zero, but it is small.
Okay.
So the vast majority of children with NASH are not going to develop end-stage liver disease in childhood. A small number do. All big centers have seen it, but that's uncommon. The real thing that we're seeing is the 25-year-old who's probably had it since they were 12, whether they knew it or not. That's where it's really starting to turn up.
And that's great to hear. At least, going back to the very beginning of our discussion together tonight, it was, is the family going to engage enough to get that child to be able to make those changes, to at least get them through their childhoods, then they can take it on themselves and be more responsible for themselves, right? As they become an adult, to maybe make those changes a little bit more for themselves, that, they don't progress to end-stage liver disease just as children.
Right. So we certainly do see that there are a lot of, say, young adolescents who struggle to make all the kinds of changes that they may need to, that have the cognitive development, and then in late adolescence, they're like, okay, I get it, I understand it, I'm ready, and do really well. I think the critical thing is they have the advantage of knowing that they have the problem, and that
Right.
it's such a common problem. There are so many teenagers who have NAFLD and NASH and don't know it.
And that's the scary thing, right? Because then it's how bad is it going to be when they finally are diagnosed as an adult, and then not even having the information or how it had been progressing for the most of their life.
And where that really comes into play is, so they already have this condition heading into early adulthood, don't know it, and then in early adulthood is where a percentage of them will develop very common young adult behaviors of drinking and drinking at parties and binge drinking and the very kinds of things that create the highest risk for that further progression of their scar tissue to cirrhosis.
Right. Let me take a look here and see if I have additional questions. Let me pull out this box. Nope, I think I covered the ones that came in. I actually had a question from something you had mentioned earlier within the presentation, that a lot of the times, you know, when this is undiagnosed young, it can lead to like inherent issues with even just development, and that like specifically like bone loss or bone development issues. And I know personally from adult liver disease, I mean, we're always screening for these things. So, I mean, how often do you see children actually have significant bone, I guess, demineralization or issues with growth?
Yeah, so we actually just published a paper where we looked at a couple hundred children, both with and without NAFLD, and saw a fairly strong inverse correlation between liver fat and bone health, bone density. And so higher liver fat being associated with lower bone quality, bone density. And so I think it's the population has this as a risk in terms of how often do we see overt, we don't call it osteoporosis in children, but how often do we see overt, you know, low bone density? It's still a relatively small percentage. You know, depending on how you select, it could be 5 to 10%, which to already have that to me is a lot.
Okay. All right, it looks like, well, I definitely did cover the questions that came in. Dr. Schwimmer, is there anything else that I guess you particularly, you know, your interests in, I guess, research, right? Because you definitely seem to be involved. Is there anything that you're, you know, looking into right now, or anything that we can expect to see coming down the line?
So we have a study that's pretty far along looking at the genetics of this condition in families.
Great.
We have a study, as I said, where we're looking at some of the long-term outcomes in the population here in San Diego. I think that's certainly one of the things we've been waiting for a long time to be able to put together. So I look forward to knowing the story and then being able to share it.
And of course, it'd be highly anticipated to have like a San Diego-based study first, since this is where we are. Right? So
Exactly.
Really...
Yeah, very much so.
All right. It's a bit early, but I mean, I feel like our discussion was great. We learned a lot, and I'll just give you a couple of moments for anybody else with their last-minute questions to come in. Otherwise, this has been great. Thank you so much for this on National NASH Day.
Yeah, terrific. Thank you very much for having me.
All right.
Take care.
Well,
okay.
All right.
Bye-bye.
Well, thank you. Thank you all for coming tonight. We really appreciate Dr. Schwimmer's presentation and being able to share so much with us. It's clear that there's still so much to learn, and we hope that we will be able to make all of our advancements and, you know, save more lives. So please join us again for more of our webinars, and we've really enjoyed your participation, and we hope you have a great night.